All right, team. Welcome back to Plastic Surgery Untold, greatest podcast in the world. Appreciate you guys tuning in, listening. We got our celebrity cast here today. We're going to be talking about internal bra. Should I get one during my breast enhancement? And what does internal bra really mean? But before we get to that good stuff, and I appreciate you guys tuning in after Gilbert made the last episode weird. So if you don't know what I'm talking about, go back to the previous episode. If you do know what I'm talking about, thanks for enduring. Let's go around the room. Let's start this time. Celebrity, what's going on?
Not much, man. I'm finally back. I had an Achilles injury, so back running again. Yesterday,
That's a weird injury from a stationary bike, but that's interesting.
it had me on the stationary bike for a hot minute. I did not like that. I was like watching the paint dry on the wall for weeks on weeks. So 4 weeks off running, and I'm finally back. Now I'm like 2.5 weeks in, so felt good. I ran 6 miles yesterday, and unfortunately had some work stuff early in the morning, so got out the door at 11:30. It was 100 degrees.
Yeah.
10 out of 10 do not recommend running 6 miles when it's 100 degrees. So I'm back.
I feel like the challenge does good for you.
Yeah, no, it was good. I like it too because it's almost like a sauna. Like it's like a mentally, it just makes you kind of grit your teeth and fight through it. So I guess I'm like a little bit sadistic. I don't know.
G, what's going on with you?
Um,
You're looking rather damper today. I like red on you. That's your
thank
color,
you.
dude.
I've
Looks
gotten
good
a lot
on
of
you.
compliments on this jacket before. I appreciate that.
Okay.
Thank you.
What's going on?
Well, as I alluded to in the last episode, had been doing a lot of traveling, and you limited me to just one of my travels.
Yep, true.
My last introduction. So maybe I'll talk about another one today.
It's been our new phase in our podcast. We're trying to limit Gilberto's time. He doesn't realize this is a phase-out method, but so don't tell him if you're listening.
But no, in all honesty and all joking aside, like I said, April was a busy month for me, but I felt like it was a really great month. I learned a lot. I attended a couple different courses, of which, again, like I mentioned before, I'm really excited to bring back to Austin Plastic Surgeon. But one of the other ones I attended was in Fort Lauderdale with Dr. Shino Bay, and I did a lot of interesting stuff with biostimulatory injectables, which we'll talk about in a future episode too. But really, really interesting stuff. It was very different from the other course that I took earlier in the month of April, where that one was kind of geared more towards HA fillers, which people are more commonly used to or know about. This one is more about using your body's own collagen to stimulate some of the improvements that we see in the skin. So really neat, and I'm hoping to talk about that a little bit more later on.
Was this one life-changing as the other one was? Or
It
or
really
not
was.
quite?
It really
So
was.
which was more life-changing, not to put, Dr. Shino Bay and Dr. Arthur Swift against each other. If you guys are listening, you're both great, but Gilbert's got to pick one.
So the thing is, they're life-changing in their own way.
Do you think they're subscribers?
I
Did they
cer-
mention
I
anything
certainly
about it?
hope so.
Okay.
It'd be great if we could get them on.
Yeah, maybe we'll shoot
Yeah.
an invite. We'll tag them, see if they're interested.
Yeah, but no, it's very interesting because they have different approaches to the way they use these products. Dr. Shino Bay is very focused on like regenerative medicine and using the body's own collagen producing effects, where Dr. Arthur Swift uses a lot more of the HA fillers, which help volumize the tissue. And there is there's argument that there's probably some collagen formation from that as well because of the injury from the injections and such. But they're just very, very different. And it's really interesting to see both perspectives. And again, hoping to bring all that back to Austin.
But here in Austin, right in the middle, you're combining the both worlds.
Yeah. And interestingly enough, one was on the West Coast, one was on the East Coast, and I'm just bringing it here to
Third coast.
Yeah,
To the third coast.
to the third coast.
Oh, yeah.
Wow.
Love that.
Well, thank you, Gilbert. All those people followed you with you, so the people trying to buy a house in Austin don't thank you for having everyone follow you here. But yeah, thank you, Dr. Weinfeld.
Yeah, I mean, I think it's worth mentioning that this is our first podcast session subsequent to the ASAPS meeting that was in San Diego. What is that, roughly 4 weeks ago? Something
Yeah,
like that.
just about a month.
Yeah, just
And
about a
part
month
of the
ago.
reason that we had a little hiatus, we had House of Modern Beauty. Thank you, Real Soft, for that.
Yeah.
And then San Diego, which was a busy week for both of us.
Yeah.
You actually spend, because you do the Rhinoplasty Symposium and then the aesthetic
Yeah,
meeting.
it's almost a week away. Yeah, I mean, but it's good. I learned so much at those meetings. Some of the the highlights of that was really starting to understand the evolving role of preservation rhinoplasty in terms of the options that we can offer patients. And then, as we have talked about in our last podcast and what we're talking about now, there are a lot of changes afoot as it comes to cosmetic breast augmentation. And so I made sure that I went to as many of the sessions as I could that focused on that topic so that we can educate our patients and provide the best results to them.
I think it's always interesting because people are like, well, why does stuff change? And I was like, I personally don't want to be 20 years from now sitting here doing the exact same thing that I do now with technology, with our understanding. Even something as basic as anatomy, I feel like we still continue to evolve our understanding, and as our understanding evolves, as newer products, techniques, things come out, we continue to evolve with it. And I feel like the day that I stop trying to learn and evolve is the day that I should stop practicing.
Without a doubt, if you're not changing, you're moving backwards. Because it's such a complex endeavor. There's like an infinite number of things that we are actually doing for a patient in terms of planning for a procedure and executing a procedure, that if we at present think that we understand that infinite array of things that we can do to make it the best procedure possible, we're not trying. And we need to always be trying to understand even the most minute detail so that we can give our patients what they need from us.
New question. Talking about new stuff, and I got a few nuggets I want to share with you guys. Not quite ready. Maybe the next episode. But so let's jump into the good stuff here. Talking about new techniques, new stuff that we've learned. Internal bra is a question when we're talking about breast enhancement, secondary breast surgeries, breast revisions, whatever you want to talk about. And we can get into that in a minute. Internal bra is definitely a not a new term, but a term that's definitely become in vogue. And maybe we can discuss what internal bra is, who's a candidate for it. We've even started discussing something called a prophylactic internal bra, which I think is new. I think that is, a little bit forward thinking, because I think the goals that we have, whether we're talking about breast surgery or something else, and you mentioned in our last episode, for those of you that listen, that, most people, if you're getting your first breast augmentation, in your 20s, you have to at least strongly consider the fact that it's likely that you'll have another surgery. And I tell my patients that it's likely, these aren't going to last you the next 90 years of your life. You no longer have to change these every 10 years, but unlikely that you're not going to want to or need to do something at some point.
Yeah.
But we are always trying to improve our techniques and everything that we do to minimize that risk, to try and get you as much lifespan out of that breast enhancement as humanly possible.
Agreed. Yeah. And that's where the internal bras, if you will, come into play, because they can help control the placement of an implant and really perhaps increase the durability of the results. Should we step aside or backwards just for a second and talk about what are we even referring to when we're talking about an internal bra?
Yeah, 100%. I feel like internal bra was this term that, and that kind of was a slang or social media term that kind of came up that truly refers to what we call as and this term may not be completely true anymore when we talk about prophylactic internal bra, but in general it used to mean like a capsulorrhaphy, where we go in and do something that's going to tighten that pocket and hold the implant into a better position.
Yeah.
Because I would say if you even went back 4 or 5 years ago, 98-99% of my internal bras, and I'm using quotation marks here, were a capsulorrhaphy done by sutures, where someone came in because their implant had either bottomed out, so kind of slid down, or slid towards their armpit, and we're trying to get it into a better position. And that's where the term internal bra came from, is because we're tightening that pocket, readjusting the pocket internally to hold that implant into a better spot. Because I think we all understand, if you're just dependent on the skin to hold the implant into a good spot, that's a setup for problems and not giving you longevity.
Yeah, exactly. So yeah, let's just definition of terms, nomenclature. So you've got the skin and the breast tissue. So manipulations of that, we're not going to call internal bra. What we're talking about is the deeper tissues. Often when we're going back to make a revision, doing something deeper than the breast tissue, deeper than the skin. We're going to call that internal bra. And we can break that up into two categories. We can do an internal bra with the body's own tissue, or now what we are going to spend some time talking about is how do we employ external materials to help supplement the body's own ability to hold that implant in place. So you've got capsulorrhaphy, which is what you were talking about, bringing tissue together, using sutures to hold it together. We're going to call that, sort of the body's own tissue. And then adding something to it in the form of bioabsorbable mesh, we're going to call that something else.
Well, and I think this is important because you talked about it even with the rhinoplasty and stuff. When we talk about doing stuff like, preservation, we're always trying to improve these methods that they're less, the recoveries are easier, the procedures are less destructive to the tissues that you have. And so, in the past, we were limited with these internal bras because if you don't have an implant, then you haven't created this capsule. So there's not this material deep inside because everybody performs a capsule, which is some layer of scar tissue that forms around the implant. And, this is, almost like the porridge and the three bears, right? So you want it to be just right, where there's some capsule around the implant that holds into a good position. If it's too tight, you get capsular contracture where the implant feels really firm and can move up. If it doesn't form enough, then it can go off to the side, it can bottom out. And this is where trying to do some of these internal bra techniques, we're trying to take some of that variability out of the equation so we're not just doing it and hoping for the best.
Yeah. So why don't we just take like a case example? So let's talk about that patient that we see occasionally where they've had a breast augmentation that served them very well for some time. They're happy with the size of the implant. They don't have a thick capsular contracture, but in time their tissues have weakened a little bit. The implant's a little bit low, and it has kind of worked its way a little bit to the outside, and they want to have a sort of a secondary breast augmentation where, and let's say that patient doesn't necessarily have a lot of loose hanging extra skin. It's really one that this sort of archetype patient is one where it's just the implant is low and to the outside, and they just want that perky look that they had 5-10 years ago to be restored. So really now we're talking about sort of supporting the implant. Now, before the meshes that we have available to us, just walk us through real quick, what would you do with that patient?
And I don't want to misguide people because a little bit of movement of that implant is fine. So we're not trying to say that the implant needs to be perfectly still, because part of the benefit of the gels and these things is that you have some of that movement that keeps it soft. So a little movement to the side, a little movement down is okay. But we're talking about once it gets beyond that spot.
Yeah, where it permanently kind of comes to sit with gravity low and to the outside.
I would say my answer, over the last 5 years has definitely evolved. If we went back, when I got out of training and even when I was in Miami, I would have, if we're going to go back, I always have a discussion with the patient about where are we with implant size. Because if you want to change the implant size, this is a time to do it and for us to at least have that discussion. Two, if you have a older saline implant and you've already had these issues, I will typically push them to use one of the new Gummy Bear highly cohesive gel implants, because I do think that decreases their risk, that puts less stress on our repair and gives them the best chance for success. And then from that, this is where things have changed for me. In the past, I would have done the suture repair where I suture that capsule together and try and line that up. The issue with that is it was a little hard to control, so it definitely took more time in surgery. Two, I think there's a little bit more variability. Three, it was solely dependent on the strength of that capsule to hold those sutures and not break and have a relapse. I think 4, if I'm on 4 already, sometimes the breast looked a little square or right angle. It was hard to give them a nice natural swoop. Most of that did, in all fairness, get better over time. But, for patients, it can be concerning. You're going through this big surgery, and all you're hearing from you and I is like, be patient. And in the vast majority of people, it does round out and get to a good spot, but it's 3 or 4 months for it to get that nice shape. I've now evolved to doing something that I first saw described by Dr. Calabrese, and he may or may not be the one who invented it, but I give him credit for it, is something that we call popcorn method, or where you actually use heat to control and get that capsule to contract. I love this because I think you're thickening that capsule. I think you have a smoother transition. It's a lot easier to do, so I do some variation of pocket adjustment to everybody now.
Yeah.
And then I would say now, most recently, I've switched to. Most of the time, I'll do the belt and suspenders. I'll do the capsule with some of the thermal, the popcorn method, and also use one of the meshes. And we could talk about, why the meshes I've switched to reusing them, because they're not new, but there are newer ones on the market.
Yeah, yeah. So let's walk a patient through this. So envision your breast implant is lower than you want it to be, and it's further to the outside, and you've had a prior inframammary incision. So where the breast meets the chest, you've got an incision there. And you come to Dr. Franco or myself and you say, I'd just like it higher and more to the inside. And again, this is different than motion, natural motion, as I think you're very wise to point out, totally normal, desirable, in fact. So what we would do is bring you to the operating room, discussing the techniques up to these meshes that we have available to us, and then we'll talk about what we do afterwards. But you make the incision, most likely where you had it before, take out the implant, and then you use a little bit of thermal energy. So you put the Bovio on a little bit of a higher setting, and you go to the outer aspect of that breast envelope and to the lower aspect of it, and you just apply some of the heat, which kind of shrinks it like a sweater in the dryer, and you shrink up some of that tissue, and as you said, stimulate some additional collagen. You may supplement that with some sutures, although if you can avoid doing it, that's good, or potentially better, because you don't get more of a square appearance, perhaps, or even puckering, which you can kind of see through the skin. But if you need to add a little bit of sutures, you can do that. So that's kind of what we did up to, relatively recently. So now what we might do, and we're going to talk about these materials, is now what we might do is supplement that. So whether it be the thermal capsulorrhaphy, the sort of sweater shrinking technique, and then plus or minus the sutures, we're going to add a bioabsorbable mesh there that helps supplement that, and really kind of what the body's going to do is going to respond to that mesh, and it's going to create its own collagen that kind of welds everything together over the whole length of that tissue that we have. So from just below the armpit all the way down, swinging down around that gutter of the envelope that we just created to the inner part of the breast, and that mesh is going to be replaced and supplemented by the body's own collagen, creating this really new natural capsule that is really the dimensions of which were designed by Dr. Franco and myself and other surgeons to help support for a longer period of time that implant.
And I love this because, and this is what sometimes can be confusing, because all of those can individually be considered internal bra, right? So, putting the bioabsorbable mesh, it could be considered internal bra. Rechanging some of that pocket could be considered the internal bra. In the old days, we would even sometimes take part of that capsule, flip it over, resuture it, reline it. If we don't have to be so destructive on the internal portion, we would rather not. That's where some of these have come apart. I'll tell you, for me, the reason that it switched recently is that I feel like the types of mesh available has changed a lot. And that's why I'm much more aggressive about offering them. And not to get us off on a tangent, but the big reasons that they're more on my armamentarium, if you would, of things to help patients is the cost has gotten much more reasonable for patients. It wasn't too long ago that, some of these specialty meshes were $3,000 a piece, So if you're doing both breasts, you could easily spend $6,000 on just the mesh and nothing else.
And just to kind of clarify, verify, when you're referring to those older materials available, are you referring to some of the animal and human derived collagen sheets?
Some of the dermal matrices, for sure. And then I don't know how you felt, but even in my hands, they were a little bit harder to use as well. Sometimes suturing them into place was a little bit harder. Sometimes getting them to adhere to the soft tissues was a little bit tougher. I don't love using drains around an implant. And some of those, if you didn't use drains, you were at a higher risk of some other problems. So, and I'm just trying to give people an idea of why we've transitioned. It's not just that.
Well, it really is a game changer. It's a real game changer because one, the expense of those, whether it be the Alloderm or the Stratus, which came from Alloderm from human, Stratus from pig, porcine collagen sheets. Those actually they did help reinforce that new gutter that you created that really helped keep the implant where it was. But you had to suture those in many different locations with the idea that you might not get kind of collagen to collagen, sheet to sheet healing the way you wanted. Whereas these meshes, really just their mere presence really stimulates some collagen production. I mean, also because they're a mesh and they're woven as opposed to a more sleek, smooth piece of collagen, just their coefficient of static friction is higher, and they kind of Velcro themselves down a little bit. I know we've talked about this offline so many times, but you really just put them, it's kind of like set it and forget it a little bit. I know you put one suture, I put one or two sutures to really just hold it in place, really, kind of where like the top bottom, if you will, just so it's not shifting, or to hold it in place as I put the implant in. But I feel so much more comfortable that it's going to stay where I need it to stay.
And those are all the reasons that I've slowly started being more and more aggressive about offering them to patients, because there's risk for everything. We've talked about this on our other podcasts, and I'd hate in the past ask you to pay a ton more money for something and then have a problem, and so that's why I think we were always super selective, because if somebody's listening, it's like, well, why didn't you just offer this to me all the time? And it's like, well, I didn't want to create a problem for you. I didn't want you to spend a bunch of money on something that may or may not help you. And I feel like you talk about it all the time, kind of cost and rewards. What do you get for that? I feel like as that cost goes down, there's not as much pressure that like what this is going to do, because we're getting you into a good spot. I think the complication rates are much, much lower, because pretty rare because of that woven type mesh stuff, Seroma, some of these fluid collections that we worried about with the old ones. I knock on wood, I have not seen that with these. And by design, I think it'd be hard.
Well, and these materials, because they're essentially man-made, they can be terminally sterilized, meaning that you open that package and you have every bit of confidence that there's no bacteria. Whereas, unfortunately, as good as the porcine pig and human-derived collagen sheets are, well, I shouldn't say this, but some of the preparations are not actually terminally sterilized. So they're like the bacterial count is super low is not nothing, and that's an important thing to note. So I feel so much more comfortable with these meshes, as you have really already hammered home, price, but also we have more confidence that they're not going to bring along a whole host of complication baggage.
And the other thing that people worry about, because they if anybody who stayed up late sees these infomercial about meshes and like all the bad problems.
Really important to point out.
And these are very different, and you already alluded to it, is that these actually stimulate this collagen, thicken up this capsule wall, hold that implant in place. And the idea is we're just trying to hold that implant in place for the first few months. And the exact amount of time, I think, is still a little bit debatable. But most of these newer meshes, after 9 months to a year and a half, the body slowly absorbs them. So there's nothing left permanently that's going to cause some of these long-term problems. So I think that's a game changer.
That's a game changer,
And most people don't even realize some of these new meshes are actually made of the same material that we used for the sutures in the past to close that, but in a much more tight, woven, and basically 1,000 of these sutures put together. So if you could imagine if we put 1,000 sutures and lined your whole pocket, that's what we've done. But somebody's done it for us, so we don't have to sit there for 6 hours.
That's a good way to think of it. And I'm so glad that you pointed that out, is that these materials are not experimental in the sense that these are sutures we've been using for tens and tens and tens and tens of years. It's just that the way they've been prepared, the shapes, the sizes that they are, the material that's created out of them is entirely new. And when we say new, we don't mean like new yesterday. I mean, they've been trialed in patients for many years. But it's such a refreshing thing that we have these to offer our patients.
It's funny because Gilbert and anesthesia can jump in on this, but one of our social media people asked me like, "Hey, can you do a TikTok on who's a good patient for these new meshes?" And I stopped and I was like, I don't know, because I feel like, if we come back to this TikTok 6 months from now, some of these indications may have changed, and I think they're going to get broader and broader and broader to the number of people that we offer some of these to, know, and because I think you and I are the same. When something's new, we don't want to necessarily just offer it to everybody because it's the newest thing on the market. We like to see that this is helping people. I like to be able to tell you that you're getting something for the money you're spending for this.
Yeah. I think this, you brought up something. And so we're really fortunate to have Travis and Gilbert here, who are like super knowledgeable about medicine, very well trained medicine, about plastic surgery also from different perspectives, but to some degree are naive to what we're talking about a little bit. So I think it's great to have like sort of an expert, but not an absolute expert, kind of ask us some questions. So based on what we've already talked about, well, like what kind of questions does that stimulate for you guys? Because I know your question will be thoughtful and it's going to help our patients understand why we might be suggesting these materials for them.
Yeah, so I luckily get to see you guys use a lot of these different meshes, and I mean from all the way from Stratus, 5-6 years ago to some of the newer stuff that you guys are using today. So out of those, I mean, when you're doing these pocket revisions and without doing a mastopexy or a breast lift or anything with the skin, what is the level of lift and support that you guys can achieve with these meshes versus just a simple suture and trying to close down that pocket, if you will?
I mean, I would say for me, the difference on the table or immediately post-op is actually unperceivable. For me, these meshes are more about longevity and trying to help people. And
That
so
makes
this
sense,
is and this is where the going back to the evolution of who's a good candidate. Like for me, in my mind, someone who's had massive weight loss, I feel like we should at least talk about this because I feel like they're at higher risk. I feel like people who are using larger implants,
Yeah.
we should at least have this discussion about this. I think depending on their anatomy, if you're very kind of barrel chested where that implant looks like it might be more prone, I think that's an indication. Talking about how these keep changing. Somebody, when we were in San Diego, gave a talk about, maybe even people who have tuberous breasts might be a good patient because you're opening up that fold and now you're asking this implant to sit on something that you've just opened up.
Yeah.
And so I thought that was very insightful and very thoughtful and something that at least made me think about it.
Yeah. Because the minute you asked that question, I was kind of thinking what you just said. So let's reiterate that for the patients. Like the on table result, likely we can achieve the same thing, but the result that we create on the table is not the result that patients end up having 3 and 6 months down the line in some cases. And so we never leave the operating room without thinking that it's perfect or that it's going to be perfect. But what these meshes are likely allowing us to do is to have the confidence leaving the operating room that what we designed in the operating room, what we were trying to execute in the operating room is what they're going to get at 6 months and 6 years, 16 years, maybe not 60 years, but, it's going to give us an enduring result. Can we promise that that's going to be the case? No, we can't, but it makes me feel a lot more comfortable that, if a patient is spending X amount of money on the procedure, if they spend X plus a tiny fraction of X, that it's going to make that sum that they paid for the procedure a real value, So that's where when it used to be, $3,000 or $4,000, like I don't know, but because nothing's promised, nothing's guaranteed in terms of how this mesh is going to be performed. But when we're talking about these meshes costing, fractions ish of those original costs, then I think it's a worthwhile insurance policy. Not the way that an insurance policy guarantees things, but it creates a much higher likelihood that what we intend to create in the operating room, what we left the operating room with a great plan, with great execution, is what they're going to get down the line. And that's what we want for our patients. We want them to get great value for their money.
And I feel like this is where we are at this time point in plastic surgery history, is trying to figure out a little bit better statistics of how much does this help, which mesh, because there's a few different ones are best for each patient and who's at higher risk. And so, the two that I use most commonly are one called Galaflex, which, lasts about a year and a half or so. And then there's a newer one called Durazorb, which is considered the softest mesh on the market. So I think there's a role for both depending on the special situations. And that's kind of where we are now, is figuring out which is best for each situation, who's at highest risk. So I would love to be able to give people more statistics. And I think that's what we're gathering right now is like, how much does this decrease your risk? What percentage does this help?
Yeah.
Because right now I think we feel like it helps.
Yeah.
We can't tell you a percentage.
Yeah. I think that's really fair. That's extremely fair, really important. I think really we are at a phase where we can't say with certainty that one's better than the other. I think that we can say that we have some intuitions about that. That if, let's say, we feel like, and it is a little bit of a feeling until we have 100% of the data, that if we feel that a patient would benefit from a little bit, maybe not stronger, but longer term strength to their support, we might lean towards the Galaflex. Whereas if it's a patient that we want just a little bit more confidence that our tissues are going to heal together and stay together the way that we want, we might lean towards the Durazorb. None of those are absolute rights or wrongs. None of that is 100% science-based at this point. But that's how a lot of plastic surgery is, and you just have to have a thoughtful surgeon who really explains sort of what their decision-making is and how it might influence, your decision-making as a patient, and understand that that in all likelihood, what we believe is going on actually is what's going to go on.
And I feel like there's the two extremes for this, right? So there's the extreme where I would strongly recommend it and maybe even go to the point to tell you doing surgery without it is not worthwhile. And Gilbert, our quote of the day expert, can correct me if I'm wrong, if I'm misquoting, but I think it was Albert Einstein that said, repeating the same activity over and over again, expecting a different outcome, is the definition of insanity. And so like when somebody comes to me and has had 2 or 3 breast surgeries of trying to do some type of internal bra, to just go in and try and do the same suture method or same, thermal, popcorn method to the thing without employing one of these new meshes or doing something different, to me just doesn't make sense, especially, in a tight-knit community like Austin, where I'm like, hey, the person that did your last surgery was a very good surgeon. So for me to go back and do the exact same procedure and expect that this is just going to turn out better, I feel like is unlikely. And so I think those are people I feel really strongly that we have these new tools in our box.
Yeah. I mean, it's such a subtle thing, but it makes me feel so much more comfortable heading into these kind of surgeries that I'm doing everything I can do, and I don't feel I don't feel uncomfortable about offering this to a patient, because I think with those lower costs, lower potential for complications, that now I'm really educating my patients about all of the possible options. Whereas in the past, I did feel a little uncomfortable bringing up Stratus or Aldrin because it was so expensive, and I think in some ways it was a little bit conceptually flawed, because you couldn't be certain that you would have that smooth collagen sheet heal to a smooth capsule. Whereas again, the very nature of these materials and how we believe that they're behaving is kind of conceptually different from that in a way that I feel a lot more comfortable with and offering my patients. That and the price.
Can we talk a little bit about, kind of where we're at and where we're evolving to? Because I think we can both pretty strongly agree. Someone who's had a revision and needs another thing, I think we feel pretty comfortable recommending something like this. I think someone that's looking for extra support, I think some of our massive weight loss people who we have some reason to have a concern for their soft tissue, we recommend them. I think evolving even more, I've even started bringing up to some of my patients this prophylactic internal bra. So any of my patients that are going with larger implants, I try to at least have this conversation, because
and is that even for a primary aug?
Even for a primary aug, and this is because that has been well shown in the literature. The larger the implant you go, the higher the risk of needing a secondary surgery becomes, because of the weight of the implant, because of the size, because of the stretch of the tissue. So what can we do to decrease that? I think some of the people, like we talked about, that have a fold, other stuff. So on some of my primary breast augs, we've talked about this for sure. And then maybe I can get your thoughts on that. And then the second part of that is, what role do some of these soft tissue support like Galaflex, Durazorb, these internal bra meshes, bioabsorbable meshes have in breast reductions or mastopexies without an implant? Which would be a little bit different, but something more on the horizon that people have played with. Again, I think these materials give us a little bit more options.
Yeah. So for the last minute or two, just for our future patients and the audience out there, we're talking about the preventative use of one of these materials. Now, it's really important to kind of qualify that. with the fact that, so we're not talking about a revisionary procedure. We're talking about trying to anticipate the kind of things that can happen with a primary breast augmentation, or you brought up mastopexy, so breast lift, or even a breast reduction. So what we're trying to do, and we can't guarantee that it does, but we're trying to prevent some of the known challenges that occurs. So let's talk about the breast augmentation, where you brought up the idea of a bigger implant, or maybe a surgical plan that involves lowering the fold, right? So your tuberous breast is a good example of that, or just a high fold, but maybe not tuberous breast. Where so the inframammary fold, again, where the breast meets the chest internally, there is a thick accumulation of collagen there that really serves as a barrier for the implant to, or a potential barrier at least, for the implant to kind of sink lower within the body. But there are some procedures in order to achieve the aesthetic goals that the patient and the surgeon has decided are important to the patient. You actually have to sort of incise through that, lift up that thick collagen attachment to the underlying structure. So you have to lower the fold or disrupt the fold. Well, that can create a problem because you no longer have that natural barrier for the implant sinking lower in the body, and you can get bottoming out. And that's where the role of one of these meshes really is going to demonstrate a lot of utility, because you can lower that fold and then you can put the mesh to line that new gutter, that new junction of the breast tissue or the chest tissue and the deeper chest wall, and you can line it with that to hold that implant in place while your body replaces that mesh with its own collagen, and really in some ways replicate or reconstruct that collagen netting that your body used to have there as the inframammary fold. So that's a good example of how these might play a preventative role instead of sort of treating a problem in a secondary breast surgery.
And I think this is where one of the ones that we're truly trying to define, like who's at higher risk, who does this help the most. And so I think there's some extreme cases where we get a really good feeling, but still trying to define that. And so, and just because sometimes people see our podcast or Instagram, wasn't this, offered to me, or am I a candidate for this? And we want to offer you what we think's best, but we also don't want to offer you stuff you don't need.
Yeah, and our understanding of what best changes, and really, these conversations are coming off the heels of the meeting where we had a lot of people who had sort of early exposure to these meshes on study, are really presenting their findings, and now we're able to offer it to our patients. So they've a lot of them have kind of not just come to market, but they've come to market. Where other plastic surgeons who had their availability on study are now relaying their experiences, and because the cost is much lower than the alternatives, and because the potential complications are also much lower, we have the confidence to offer them to our patients now. Whereas honestly, 6 months ago, a year ago, that was really not something that we could offer our patients. Yeah. So patients who had surgery before, they should in no way feel shortchanged by that. It's just that this is one of those wonderful new tools that we can offer our patients.
And evolving practice.
Exactly. Yeah. We don't want to walk backwards.
This reminds me a lot about kind of that time over the past 5, 6, 7 years in anesthesia, where we've kind of shifted our mindset with nausea prophylaxis, right? 5, 6 years ago, we're trying to just throw everything that we can at these patients while doing kind of the same general anesthetic and hitting them with a bunch of medications that help with postoperative nausea and vomiting either during the case or afterwards. And we had a couple medications like Amend and some of these kind of novel anti-nausea medications that were price prohibitive at the time for everybody getting it. And now we have ways to kind of identify who's at higher risk for nausea and vomiting, and the price of these drugs has kind of come down. So now if we identify these candidates, we can start to apply that to more patients. So I think it's very similar to the meshes. It's we're constantly evolving our practice and seeing what works, what's coming to market. Okay, that's been on the market for a little while. The price is starting to come down. Now we can offer this to a wider array of patients. Now, instead of doing this, we can do a total IV anesthetic. If we know that this person's had issues with 3 different providers, and I know they're all fantastic providers, now instead of trying the same thing 6 more times, let's change the game and do something that is a little bit different.
So, I just thought about this. In many ways, what we're talking about sort of in a more macro fashion in breast really relates to some of the information that you learned from Shano Bay with regard to stimulating the body's ability to create its own collagen.
Yeah.
With that in mind, do you have any questions for us? You're always very thoughtful.
I did have a question, and it might kind of backtrack a little bit to what we were talking about earlier. But so in our last episode, we were talking about submuscular versus subfascial implants. And one of the things that you guys mentioned was how with a subfascial over the muscle but underneath the fascia implant placement, there may be some risk for some rippling in the upper pole of the breast. I believe that was the phrasing. Would mesh over that area help minimize the appearance of some of that rippling?
I think this is a great question. I almost tell people, and when I grew up, Cadillac was like the car. Now maybe it's like a G-Wagon or a Tesla truck or something. I don't know. But like if somebody's like, I want everything possible to decrease my chance of, rippling, support, everything. No question, you could do like one of these extra cohesive breast implants. You could do some of these mesh sling stuff because I think one, it's going to thicken up that capsule, which is going to give you some of what you were trying to achieve with the muscle. I think it's going to hold that implant in a different place. It's a talk for another day, but I think it's replaced some of the stuff that benefit from textured implants, without some of the downsides of it. Conversation for another day, not to go down that rabbit's hole. But no question, I think it can help thicken and protect some of that from rippling. So I think there's the combination of the highly cohesive gels and the mesh that would be is a really interesting and I think frontier for this.
One word really sums up my answer, and you kind of said this, but may. I think the real answer to your question is that it may help with that. And so I think the way that conversation for me would work out is, so we have, and really audience patients can go back and listen to our last podcast, but there's now options to place the implant above the muscle. And so, part of the conversation actually you and I had in our role play was that above the muscle might lead to more rippling, right? So, the conversation would be, I've got the patient who I really love the idea for all the reasons, all the pluses, really the idea of above the muscle breast augmentation. I'm a little concerned about the rippling. So I'm going to make that decision, Dr. Weinfeld, to go above the muscle. But is there anything else you might say or anything you could offer me to potentially mitigate or downgrade that potential for the rippling? And so this is where I would say, I can't say that this absolutely will. I can't say that at all. But if you want me to do everything I can, you've made the commitment above the muscle, but you want me to pull out all the tricks that I have in my bag, might I suggest that we use this mesh? The data, our understanding of these suggests that it may help. I can't guarantee that it would. I would never do anything that I think is going to hurt or be a step backwards, but it may. And if you're interested in spending a little bit more money for something I can't 100% say will definitely help, let's do this.
That's like the G-Wagon approach that you're talking about.
Yeah. And it may have other benefits besides just decreasing the rippling, because probably helps decrease the risk of the implant displacement, may have a decreased risk of capsular contracture. So this is some of the stuff where I think as we work through some of these are going to make it even more confident, more easy for us to recommend these things more often. And then Phil Monkey mentioned this, what helps more, the extra cohesive gel or the mesh? And I think that's still TBD.
And maybe to kind of dissect that out even a little bit more, so Dr. Frank and I have at this point really been talking about mesh really to support the implant lower. And I think we can theoretically suggest to a patient that if we can prevent that implant from bottoming out, even if it is a little bit, centimeter or two, we're keeping that implant up, better supported against the breast tissue, and that implant breast tissue interface, if there's a slight snug fit to that, then it really sort of forces that interaction where the implant is shaping the breast, but in some way the breast is shaping the implant. And one of the ways in which especially in a younger woman, the breast may shape the implant is kind of ironing out some of those ripples that the patient has. But now if your implant sinks down even a centimeter or two, that interface between them is not quite as snug. It's not quite as a hand and glove fit. And then you're going to see potentially some of those ripples as the breast does not shape the implant as much as it did in that relationship. So if you can keep that implant tucked up against that breast tissue better, less likely to have that. Now, though, when you were asking, what I thought you were asking about, and this is where the may comes in, is can you line the upper part of that implant with the mesh? And I think the answer is, I think this is what you and I were talking about, yes, potentially. Yes, that might help. That's a little bit more theoretical. What I talked about before is slightly more practical, pragmatic. There's a little bit more science behind that. But yes, I also think, and I think you were suggesting you think this too, that lining the upper part of that implant might also help decrease the rippling because it stimulates a little bit more controlled collagen production in the upper part of that interface that might help sort of camouflage and iron out some of those ripples.
Yeah,
but may really is the important thing to say.
I'd be surprised if we're not having another follow-up podcast a year from now talking about some of our experiences and the stuff that we've tweaked.
Yeah.
Maybe a study in the making.
Yeah. I mean, there's definitely some ongoing stuff. I think we got some good things that we can look at ourselves as well. So lots of horizons. Any last summary points you'd like to drop about internal bra and kind of the incorporation of mesh into some of these? I think we've kind of helped outline a little bit that internal bra is a broad stroping statement, and then there's some segments underneath that.
Yeah, I think two things. One is that, and you talked about this, and I talked about this as well. We don't want patients ever to have regret or feel like they got something less than the best. So really, up to this point, if these materials weren't used in you, you were still getting the state of the art and what plastic surgeons and what Dr. Franco and I had to offer patients. And then from this point forwards, I think you're going to hear a lot more discussion from plastic surgeons and from Dr. Franco and myself about these meshes because to some degree, they do offer an insurance policy. Not one that's guaranteed to prevent problems, but one that we have a really strong feeling is likely to create the kind of result that lasts you longer than we once had available to offer you with the things available to us. And the reason that has happened is because the new materials are less expensive and less likely to cause problems and likely behave more the way we're hoping them to behave.
I love it. That was such a good summary. Little quote of the day.
I got one. I think this is applicable. Yeah. Milton Berle, comedian, said, "If opportunity doesn't knock, build a door."
Ooh. So we're building a door now.
Yeah.
Oh,
yeah.
Awesome.
So
I feel like we've walked through the door.
I love that.
We've walked through the door right now.
Yeah. And it's like we were talking about with these meshes, we're creating, these opportunities for patients to achieve their desired goals and giving them the best outcomes possible, or at least attempting to with these meshes.
And I hope the purpose of our podcast here is to just educate people about options. And so, something, I know there's a lot of people listening who don't see Dr. Weinfeld or I, and that's fine. There's a lot of really great plastic surgeons throughout the country, throughout the world, and even, especially even here in Austin. And so, just something so that they can have that discussion, ask their surgeon about it, and that way they have an educated decision that they can make together about what's the best path forward for them.
Yeah. Yeah. If patients at large are happier, even if they're not our patients, it's just better for the field, and thus it's better for us and for our patients.
Last question for you guys. Did you guys plan this? Because you both got a little red
saw
entourage
that.
with a little. You got a blue and red. You got a red and blue. I kind of like this. Our social media team's going to appreciate that.
Yeah. At a sort of metaphysical level, we definitely planned it.
I chose the connection.
Yeah.
Well, appreciate all of you guys listening to Plastic Surgery Untold, greatest podcast in the world, as voted by us. You can listen to us anywhere you get your favorite podcast: iTunes, iHeart, Spotify, Pandora, and then of course you can, if you want to see these great outfits, you can see us on YouTube. All right, we'll see you guys. Bye.
Bye.